It is my pleasure today to welcome our third and final very special speaker named Dr. Miriam Hoffman. Dr. Hoffman is a native New Yorker, inspired by her parents and her esteemed grandfather, who was a general practitioner in the Bronx. She has spent her clinical career serving patients in underserved settings, including safety net hospitals and community health centers. Dr. Hoffman completed her undergrad at Johns Hopkins, received her medical degree from Cornell, and completed her residency at Columbia in family medicine, where she was also the chief, of course. She had a 13-year sojourn to Boston, where she served as the chair of Clerkship Curriculum Committee, as well as many other critical education committees at the Boston University School of Medicine. Dr. Miriam Hoffman returned to our neck of the woods, regional at least, when she was recruited as the founding Associate Dean of Medicine of Medical Education at the Hackensack Meridian School of Medicine, where she now serves as the Vice Dean for Academic Affairs. She has led the development, implementation, and continuous enhancement of the medical education program. Dr. Hoffman's goal is to align medical education curricula with the health outcomes of populations and individuals, including addressing health inequities. In this vein, the Hackensack Meridian School of Medicine curriculum utilizes the determinants of health, which are all the aspects and factors that impact health outcomes, as the frame for the entire curriculum. I met Dr. Hoffman in December of 2022 when we were giving back-to-back lightning talks at a MedEd conference in Manhattan. And I grabbed a seat near her at lunch so that I can bombard her with questions. And really, I was just, and I continue to be so impressed with her work. And I just really want us all to benefit from her innovation and her experience. So without further ado, please help me in welcoming Dr. Miriam Hoffman.
Thank you so much, Elka. I mean, what an incredibly warm introduction. And I agree. It's wonderful when you have those moments at meetings where it's like, oh, you find your kindred spirit and you find your people. So I certainly felt the same way as well. So it's great to be here with all of you. And I appreciate, Elka, how you started with my grandfather and, the ideas of community and underserved. And I will just describe what you're seeing, this picture here on the screen. This is a photo from the East Boston Neighborhood Health Center, which is where my outpatient practice was when I was up at BU, and which is a really incredible place. And this is a mural that was painted on the wall kind of opposite one of the main clinical buildings of the health center, talking about all of the communities that have come through East Boston. And certainly my experiences there forged who I am as a physician and as a medical educator. And I just love that photo. So I'm really glad to be here with all of you. And thank you so much for the invitation. You can see the title of the talk, Recentering Humanism, because really we have this idea of humanism at our school as a central organizing force and really something that drives the lifeblood. And that manifests in large part in our community engaged medical education program. I probably have been too ambitious in what I want to cover with you, but I'm going to do my best and leave some time for some questions at the end. I want to share a little bit about, we had this, I got the pretty incredible call, hey, do you want to come build a medical school curriculum from a blank slate in a mission-driven fashion? And for sure, I am forever appreciative of that opportunity, and it is certainly a once-in-a-lifetime sort of thing. But I want to really say, you don't have to build from a blank slate to be able to do this. And as we've kind of unpacked what we have, how we are understanding what we've been doing and analyzing over the years, there really are ways to be intentional and start with pieces and build towards these ideas. So my hope is to give you a snapshot of what we've done, more importantly, why we've done it and what our school is in the Human Dimension program, and also touch a little bit, and when I say touch a little bit, I really kind of mean mention some of the critical aspects of content within the curriculum that you really need to kind of reinforce and integrate. So again, Flexner report, right, drove what we did in medical education for a long, long time. And in about 2016, myself and a small group of us had this opportunity to say, well, hey, if you could build a new medical school. And the very first thing we did was create the vision for the school and work our way backwards from there. And so that vision informed the what in terms of what we're focusing on, what we're teaching, but also the how in terms of how we teach and even how we structured the educational program. And I'll show you the vision in a moment, but really what we wanted to target, and I believe so strongly in medical education as a powerful force for change, we really wanted to target the health outcomes, the inequities, the poor value in our healthcare system, and really be intentional about the educational choices that we made. And so this is that sort of three-part problem that I know is not news to any of you, but this was really the driving force. How can we as a medical school do our part to address this really terrible three-part problem that we have in the United States? I know this is not news to anybody, so I won't spend time on it. But of course, you know, to me, this graph sums it all up, right? Here we are, the US is an extreme outlier in life expectancy, right? Most fundamental health outcome there is, really. How long are your citizens going to live and your populations and communities going to live, and cost. And, you know, again, I won't spend time here, but when we look at this by race, by ethnicity, here we have maternal mortality, infant mortality. I still feel compelled to mention COVID. You guys, so I live in the Bronx. I will just say I do work in New Jersey, but I live in the Bronx. But, you know, you guys know this better than anyone, right? What was really occurring during COVID. So this was the vision we came to. And as I like to tell my team and our students, my favorite definition of the vision, of the word vision, is how is the world going to be different because of the work we're doing together, right? And so this is where we hope to get to, that everyone in the region and beyond has the highest levels of wellness in an economically and behaviorally sustainable fashion. So first, just a snapshot of kind of the who, what, where, when. Our inaugural class began in July of 2018. We became our own degree granting institution and got that accreditation from Middle States in 2022. We went through the whole shebang with LCME and got full accreditation in 2023. I'll show you in a moment how our students have the option to graduate in 3 years. So our charter class 3-year grads graduated in 2021, and 2022 was our first sort of full graduation with 3- and 4th-year grads. We are a school that is entirely within a health system. So Hackensack Meridian Health is the largest health system in New Jersey. And our campus, our school campus, our hospitals span the length of the state almost, but our school campus is in Nutley Clifton, co-located with Seton Hall's College of Nursing and School of Health and Medical Sciences. So we call it the Interprofessional Health Sciences campus. So this goalpost kind of gives you a little more meat on the bones from that big picture vision as to who our students and graduates are. And so we really want them to come out with a great sense of what's their responsibility as a physician to lead for change, to advocate for change that improve health outcomes, health equity, right? As mentioned, we use the determinants of health as a frame for the whole curriculum. I'm going to show you a little bit more of what that looks like. Very central to our curriculum is making sure our students have the skills to really practice medicine effectively in the information age. But beyond the kind of one-on-one patient care skills that our students come out with, we really are training systems thinkers who are not afraid to identify problems and come up with solutions at any level, from that one-on-one patient level all the way up to the system level, using the term system pretty broadly. So as mentioned, this is how we categorize the determinants. You can slice and dice these in different ways. You don't need to worry about that. I talk to the students about this in hour 1 of medical school. We want this to be the cognitive frame and lens into which they learn everything, so that when they come out as a physician, they have a broad and integrated understanding of all these different factors, how they impact health or disease, how they impact each other, and how that needs to inform any interventions or preventative measures we try to pursue. Again, probably for this audience, I won't go into this a lot. Of course, we know that the healthcare we provide, you know, in the 4 walls of our clinical setting accounts for 10, maybe 20% tops of health outcomes. So we really need to think about all of these in an integrated fashion. This is how we conceptualize it. And again, this is where us situated within a health system really becomes very exciting in terms of the opportunities there. But we really advocate that the context of medical education needs to be expanded, right? So historically, we had sort of academic contexts, classrooms, university campuses, we had clinical contexts. What's missing there is the community context, right? And it's all of these domains in which medical education and training needs to take place. And that can produce community engaged healthcare, right? So it's community engaged education and community engaged healthcare. So just a little bit of a picture of what our school looks like. We call it a 3+1 curriculum. You guys can see my mouse, right? When I'm moving it around?
We can.
Thumbs up. Okay, cool,
Yeah.
thanks. So a 3-year core curriculum followed by an individualized phase 3. So students start from the very beginning working with their advisors and mentors, building an individualized program that meets their educational and professional goals, but also their developmental needs. And this last section of phase 2, advanced clinical rotations, is also individualized. So the students really have about 17, 18 months of an individualized program that they develop. They can do a master's and graduate in 4 years with 2 degrees, an intensive research project, clinical immersion, a community engaged project. And they also have the option of graduating after the 3 years and entering residency, generally within the Hackensack Meridian Health System. Within the 3-year core curriculum, we have a 16-month pre-clerkship curriculum, followed by 20 months of phase 2, which is 13 months of clerkships, boards, and advanced clinical rotations. At the heart of the curriculum, you can see is a longitudinal course called the Human Dimension. We actually start with an immersion in human dimension and continues throughout. Within the Human Dimension, and I'm going to go into this in great detail, pairs of students are matched up with families in communities. A group of 8 students is immersed in a local municipality. They do community health work, and it's all integrated with what they're learning in the rest of the curriculum. So for example, if they're doing anatomy of the heart in the anatomy lab and cardiovascular disease in the classroom, they might go and meet with their family that they've known for a long time and do a cardiovascular risk assessment. Then go out to their neighborhood and create a food map and assess, hey, does this family live in a food desert? Can they get fresh fruits and vegetables, and so forth. So I'm going to go into a little more detail. Here are some key features of the curriculum. Integration, we have one integrated course that our students are in throughout the pre-clerkship curriculum, so it's not fragmented. We've talked already about context community. We very much have an active learning curriculum where students are doing pre-work and using in-class time to get to higher order cognitive goals. I'm just going to kind of go through this quickly. So this is our pre-clerkship curriculum. Human Dimension continues throughout, 2 foundational courses, and then system structured. And these are all integrated courses that integrate the content from the biomedical, behavioral, social, and health system sciences. This is what a typical week looks like. And the reason I wanted to show this to you is that every week of our pre-clerkship curriculum is framed by a weekly patient presentation. And so the students start out working through, we give them a one-liner, what's your differential, what additional clinical information do you need? So they're doing that cycle of clinical reasoning from day one. That case will play out throughout the week, culminating in a small group led by a faculty. Again, I don't want to go into too much detail, but out of this, actually, before I make you get your glasses out, don't worry. Everything the students learn throughout that week, if it's about a receptor or a drug, a physical finding, a public policy, will somehow be scaffolded by that case. And so each student creates a concept map connecting what they're learning from all the sciences, and then using this frame of determinants of health to unpack it. So here's a genetic factor, here's an environmental factor. And that's how we're really trying to train their brains to think about how they approach medicine. They then go on to phase 2, transitional clerkships, advanced clinical rotations, and then their individualized phase 3 that they've built along with their advisors and mentors. We have 18 EPAs that serve as the target and the guide along the way. And I will say these are the 13 EPAs from the AAMC pilot, but we made 5 additional to really fully represent what we want our students to come out with. And each of these has milestones and behaviors and all that kind of stuff underneath it. Systems and solutions is the most explicit one, pushing the students to think about the determinants, to think about these different community-based factors. However, it's also integrated into all of these. So as we created our milestones about prioritize a differential or come up with a management plan, we are setting a competency target where the students have to be thinking about multiple determinants of health as they understand what is going on with this patient and what type of management plan might I come up with. Okay, so that was really all kind of context to now dig in a little bit deeper into our community engaged medical education program, what we call the human dimension. And I want to just share some of the kind of foundational aspects of any kind of community engaged medical education program. And again, don't feel like you have to do all of this or you have to have a brand new medical school to do this. Also, this is not specific to the UME setting. And I will show you how we've expanded, or we have begun to expand to the GME setting as well. So what is CEME? And I'm not going to read through this slide, but I've bolded some of the key pieces here, right? So this is experiential service learning, right? And it's important to note that this is not, I parachute in, do some community service, feel good about myself, and parachute out. It's quite the opposite of that, right? So we'll get into that more, but I don't want you to get that picture in your head. So experiential, right? In many ways, as we built this program, it was a behavior change kind of model. We wanted our students to really feel in their guts, what are the determinants of health, right? Because that's much more likely to make a person now think about those things, right? Than if I have the most beautiful slide set, I say, as I present to you a slide set. Okay, it's a very effective way to incorporate the social determinants of health, meaningful engagement of the community, right? And these need to not just be words on a paper. The community, your community partners need to be partners in the development of the curriculum, in the implementation, in assessment, interdependent relationships, right? And some of this is about the relationships the trainee or the learner builds. Some of it is about relationships people on your team, faculty or staff build, and it's about institutional relationships. And we know that sometimes there's long histories of difficult relationships or lack of trust or things like that. And that is all very important to think about. The community and learners collaborate to identify and address health problems. Too many words on the slide, but I wanted to put this here and I'm happy to share the slides after. Again, required. This can't be, oh, we have these 4 students who on every other Tuesday maybe choose to. No. You saw our curriculum begins with human dimension immersion, right? I'm a family doctor. Do I think we need to have a right-sized healthcare workforce to meet the health outcomes of our country? 100%. But do I think every doctor of every type needs to know all of this and understand it and incorporate it into their clinical care? Absolutely. You can be the best neurosurgeon there is. If there's no food in your patient's fridge when they get home, you're not going to get the outcomes you wanted, right? I'll talk about this a little bit more, but having well-trained staff and faculty is critical. Building trusting relationships. We'll talk about teaching methods, which do include reflection, development of deliberate practice. So a little bit more about what the human dimension looks like. A pair of students is matched up with a family in the community. They come to know this family very well through different activities in the family's home, in community-based settings, in clinical settings. The determinants of health really come to life for the student. That's that behavior change model. We train the students to help and provide benefit to the families and communities that we're partnering with. 8 students are in a small group, so 4 dyads with 1 faculty and members of our community programs team. That community of 8 is immersed and matched with a local community, a municipality. They do a systematic community assessment, including things like geospatial mapping, meeting with leaders like the mayor or the school superintendent, doing service learning work. Through all of that, they synthesize a community assessment outlining the assets and challenges that that community faces. That then leads to a community health project that they implement along with their community partners. Our students also, once they get later on into phase 2, each student does an individual capstone project. So this capstone project is based on a patient they had in clerkships, right, that they were involved in the clinical care of, and the student does a scholarly deep dive into a specific determinant of health, understanding the literature, the evidence for it, and then they have to propose solutions to address that particular determinant when it could be an obstacle, and at least one of those solutions has to be at the system level, So these are the components. So Voices program, I won't tell you how long it took us to come up with what's the acronym going to be for those families, but we call them VPs. So that's where our students are matched with those families in a 3-year-long relationship. Community health project I mentioned, and every other Wednesday, our students have on-campus human dimension sessions, small groups, large groups, workshops. That small group, those 8 students and the faculty, becomes a very, very tight and important relationship that travels with the student, certainly throughout the curriculum and in many cases beyond. Once they get to phase 2, those longitudinal sessions continue, and we have sort of a curriculum that the students do alongside it that gets at a lot of hidden curriculum stuff, a lot of race-based stuff, things that where they can unpack what they're seeing in clerkship in this very safe space. So that becomes a very important piece. Those of you who are familiar with Ballant, it's not dissimilar, a little more structured. They continue with their family throughout phase 2, and then I already described the capstone that they do in sort of the later part of phase 2. Some of our students, by the way, take their capstone in phase 2 and build an individualized program that they do in that phase 3. It could be service-oriented, education, research, often a combination thereof. These are the goals of the course. I won't read them, but I've underlined the important words, right? And the things that we focus on in those small group and large group teaching sessions, the things that our students are wrangling with in their community-based experiences, and most importantly, when they get to clerkship and they're really trying to pull this all together and understand how does this inform my patient care and who I will be as a physician. So humanism, cultural humility, health equity, their responsibility, right? I'll talk about professional identity formation a little later on, but that we really are really reshaping what you might think of who you are as a physician is. Partnerships and so forth. This last one, practice healthcare with wellness and resiliency. So it's not just about their patients, it's not just about their families they're with or the communities, it's about them. And how do you do this in a way that protects your wellness, that builds your resiliency, that prevents burnout? And this has been something in the last few years that we've really just grown tremendously, the integration between what's going on in human dimension and our student affairs folks. So within the human dimension, we have reflection, we have resiliency building, we have our students set SMART goals for themselves, for their own wellness within the curriculum of human dimension, right? Because if you're not doing that, there's no way you can sustain this. I always like to show some pictures of our various community engaged activities. And you can see here, these are some of those community health projects. So these are those projects that the 8 students do along with their community partners: food pharmacy, changing the emergency food game, educating parents on child development during COVID-19. We partner with a lot of schools, a lot of boys and girls clubs, all different kinds of community-based organization, community oncology nutrition program. You can see examples here. This is a screenshot actually from a video that we have. These are 2 of our students meeting with their VP, their person that they are matched with in the community. And this picture is our founding dean, Bonnie Stanton. And this was in the first week of our first class when we were all down on the Jersey Shore doing some service learning work together. And, she really set the vision for this school. Some more examples. These are the capstone projects. So these are the individual projects that our students do later on in phase 2. Barriers to inclusion for persons with adverse social determinants, literacy, virtual tool to determine sidewalk accessibility, promoting medical and psychological wellness with green stormwater infrastructure. So remember, environmental determinants of health are one of the central ones as well. Other examples and some pictures here. So a little bit of a snapshot of by the numbers. We've had 567 families involved. Though they come from community-based organizations, 64 different organizations. You can see the different types of projects, community leader interviewers. During COVID, we really pivoted to partner with schools and school districts, and we now have a huge initiative related to supporting schools across the state, capstone projects, and so forth. So I want to just share briefly how we have expanded this up to GME. And I can tell you that it's now probably about 3 years ago, 2.5, 3 years ago, that we realized this is all well and good, And it really seemed like I like to say when our students get to clerkship, they're not your grandmother's medical student, but then they're going to get out into the clinical setting, right? And see lots of great stuff and see lots of who knows what stuff, right? And so we started to really ask two questions. How can we impact that learning environment, the clinical learning environment where our students are going on to train? Because we could train them with all the best whatever in pre-clerkship. If it all gets undone when they get to the clinical setting, we're really undermining our goals. And number two, hey, we're part of the largest health system in New Jersey. How can we impact what's going on across this health system, right? And I like to say that we really are trying to use the academic infrastructure of the health system, because we know that students, residents, they're like water, right? They're going to get to every corner of that clinical setting. So we came up with this idea for human dimension in GME. So the idea here is, again, same goal, build a focus on all the determinants of health in patient care across the HMH system, right? For obvious reasons, probably to this group, right? To provide the highest quality patient care, to improve patient outcomes and health equity, and to really be responsive to individual and community needs. And so these are the objectives of the program. You will see pretty clear overlap, right? This is how we've structured it for the GME setting. Health system science foundations, because again, we had to account on the GME level. Sure, many of our residents come from our school, but many of them don't, right? And so we need to kind of level set at the beginning. So health system science foundations, cultural humility, leadership and advocacy, and humanism. And so really all the other pieces, this is just how we kind of organized it for the GME side. So the HD and GME program components, so there are teaching sessions that include a lot of reflection that are integrated into the different programs, whatever they call them, didactics, core curriculum, et cetera. But then very important, remember that experiential piece, that community engaged piece, that outside the four walls of the health care setting piece, right? So our residents are out in the community, and we have a group of what we call community engaged master educators who work with each program to figure out how to mold this and make it appropriate for that specific program. So sometimes the community immersion piece is more on an individual piece related to a patient that the person might have cared for. Sometimes it's more at the community level. Again, we kind of work with each program to help them build the way this should be applied in their setting. Scholarship is a piece of this. And then, the most fundamental is that the care, the clinical reasoning that's being provided, the clinical care integrates all the determinants of health. And here's just a smattering of different programs. I can share that we launched this pilot over a year ago, July last year, with a third of HMH residencies from across specialties. So it's not just the family doctors and the psychiatrists and the pediatricians, it's the surgeons. We have surgical subspecialists, OB, and so forth. And our goal is to get to be at 100% of HMH residencies. And also for that bunch of programs that are part of the pilot, we're also from different HMH hospitals, right? So we could really have proof of concept in different specialties and different hospitals. So we're now well into year 2, of which has more of a focus on the scholarship piece. We've been very lucky to get grant funding to support this human dimension in GME. And so the next wave of what we're really building out right now is what I like to call a regionalized CEME infrastructure, right? So community engaged medical education. And so what that means is we want to have dedicated faculty FTE. Our health system, we kind of organize it north, central, south, right? So there's dedicated faculty FTE and community engagement staff in the north, in the central, in the south. We also have our team here. They're all part of the same team. But that way, there's no reason the psychiatry residency at Jersey Shore can't work with the internal medicine residency, right? And those are folks who will become very steeped in the local communities around each of those clinical sites. We have worked and we have expansion planned, again, taking advantage of the fact that we're part of a health system. So our quality and patient safety, our social determinants unit, our community engagement unit, all of those we're collaborating with in various ways. Okay, pause. So now we're shifting gears a little bit, and I want to mention, and I hope I'm not talking too fast because we've covered a lot so far, so I'm glad, and then we can have time for discussion. These are 6 longitudinal content areas that are critically important. And so I'm not going to go into super detail on these, but it's really an important part of it, because what you see if you look in the literature, oftentimes, well, there might be some kind of community engaged activity. Maybe it's following all those principles I shared, or maybe it's following some of them, but often it's either optional, that's one thing, or it's incredibly siloed, right? So for these 3 days between blocks F and G, we do this, right? And that's why I think it's so important that we start talking about this and we give that frame from the very beginning, because it's just not realistic, right? It's not like our patients are going to say, well, on Tuesdays, my genetic factors are at play, right? But I'm seeing you on Wednesday, so we can talk about these other factors. And an important way to do that is in the messaging of importance, right? And we are very good, unfortunately, sometimes in medical education of sending messages. This is important and this is less important, right? And so these foundational content areas or longitudinal content areas weave throughout our integrated curriculum and are very tightly related to what our students are doing in human dimension. And it's really a collaboration across faculty and staff in all these different areas working. What are they doing on Wednesday in human dimension? Well, what are they doing in their basic science content, and what are they doing here? And we're not perfect, right? We're always trying to improve our processes, but these are things that are really foundational that you need to get to a community engaged medical education program and not just stay at that kind of community service lens. So clinical skills, and this is, we like to say, in med ed, right? Like if we can make a simple word fancier, always do it, right? So bidirectionally integrated. So our students, for example, are learning history taking, communication, right? All those things that they'll learn in clinical skills, but they're applying them with their families, their VPs in the community from very early on. They're coming to know their VP really well. And so they can really get to more sophisticated communication skills earlier, right? Because maybe it's someone they've established a relationship with, and then they're now 9 months in and they're visiting, they're doing one of their home visits, and they can tell something's up. The person doesn't really seems like something's bothering them, but they're not sharing them, right? So what they're learning in clinical skills is certainly impacting what they're doing in human dimension. But what they're doing in human dimension is absolutely impacting their clinical skills. And you want this integration and coordination to be as tight as possible, right? In our first couple years, we made mistakes like, they were doing X in human dimension, and a month later, they were learning how to do it in clinical skills. And we were like, gee, it should have been like that, right? So it's simple level kind of coordination and integration that then enables you to get to the higher level. And I mentioned this a little bit earlier, but humanism, determinants of health, growth, right? So we do a lot of kind of metacognition, goal setting, things like that in the actual curriculum, not extracurricular. And those are integrated into the behaviors that the students need that are associated with each of these EPAs that are the targets. Those are the behaviors they need to demonstrate. That's what they'll be assessed on in clerkship, right? So our clerkship assessment, feedback, and growth system is all structured around these 18 EPAs. And here's what you need to be doing under professionalism and growth by the end of clerkship year, and so forth. So clinical skills is the first one. Health system science, and I still use this slide, even though it's probably outdated. This is from, I think the first HSS book that the AMA put out, right, where you sort of care of that individual patient, and then there's like everything else, right? And you can pretend there's nothing under that shoreline, and I'm quite sure this isn't even really a very updated kind of list, but I just like the idea, right, that we can stay focused on that iceberg or the tip of the iceberg, or we can think about what's underneath. This is another much too wordy slide just to give you a sense of the content that we're covering in health system science. So if you remember, I mentioned each of these courses integrates the content from the biomedical, behavioral, social, and health system sciences. This is the content that they're focusing on in phase 1 of the HSS curriculum. And in many ways, a lot of the content they're learning in HSS is then applied in the human dimension. And so you want to make sure that there's good integration there as well. Cultural humility, right? So a big topic, but it's really important to know that cultural humility training is essential, right? And it's essential to really building the foundation to create humanistic culturally responsive physicians, right? And to build physicians who can create those trusting relationships, who can build effective relationships with the community. And I won't go into too much detail. I'm sure you guys have talked about this and work on this a lot, right? But cultural humility as a concept, but also as a method, right? Lifelong learning, self-reflection, right? Accountability, thinking about systems, all those pieces. And so this plays out for us a lot in human dimension. And actually, yeah, I was going to say, I think I say faculty development here somewhere. It's really important that you think about your faculty and your staff and the training that they need. And I can share just on that note that we have a lot of clinical faculty who come and do small group teaching on our campus in the pre-clerkship curriculum. And as our class size built up over time, and we are at 168 students per class, so we do this at scale. Building and developing those faculty is a huge and critically important endeavor. But a great indicator of, I think, the meaning and the value for the faculty is we have near 100% retention year over year in our faculty. And most faculty who leave, it's because they're like moving to Nebraska or something, you know? And that's because we've built this incredible community of practice for the faculty. And I think that's where, if you're doing this in a real and genuine way, it's not like the goal of faculty development isn't taking my expertise and dumping it into your brain, right? It's I'm a lifelong learner and you're a lifelong learner. And for a lot of our faculty, a lot of this content was very new and very different. And that, really took time over time to build that up. So our approach to cultural humility, it is situated within the human dimension, although very much faculty and leaders from clinical skills from the other content areas are involved, right? So it's integrated across the curriculum. We're trying to build a culture of discourse, faculty development. You really want to be intentional with your curricular design. And we talk a lot about framing, which can often be the pre-work that a student does before a session, right? You can't just dive into some of these topics in depth. And you guys know all of this from your experiences, I'm sure, but really being intentional to take the faculty and the students with you in a intentional sequence, right? An intentional approach. And again, we have large group learning. All of our human dimension sessions, we might have a large group session, which might have a panel. We might have patients, community members, different kinds of active learning sessions. And then they always have a small group as well. So there's debrief, there's structure to those small groups as well. Those are for our on-campus human dimension days every other Wednesday in pre-clerkship. So civil discourse, and this is kind of a terminology, an idea that we've been talking about more over the last year, because I think that there are ways that focusing on building cultural humility and other aspects, in addressing health inequities can sometimes miss the target a little bit, right? And so that's where we found that these sorts of competencies are really important to focus on, again, in an intentional way. Right. And this gets back to that recentering humanism, because for me, fundamentally, it's about humanize and do not dehumanize. Right. Do not create a false binary and put you go in this bucket and you go in this bucket. That is not humanistic. Right. And I think that we need to recenter those kind of ideas. And how do we build openness and curiosity? I mean, I don't know, are there any Ted Lasso fans on the line here? Right. That amazing scene with the darts. Curiosity and humility. I've been thinking about those words so much in the last year, right? And really, what does that mean? And then how do you develop it, right? And those are two separate questions that are both hard in and of themselves. Making sure that we are always grounding everything we do in fact and in history. And this is really hard in the, whatever you want to call this age, the age of I learn history from TikTok. Right. And that's very challenging, and algorithms, right? How do you build perspective taking? How do you build critical thinking? The world is complex, right? And what our students are going to see out in the community, in an exam room, in interactions with colleagues is going to be complex. And we need to make sure that that humanistic approach is the central guiding force. I won't go into this in detail. You'll see some overlap, things like reflection, things like practice. These are not things that can be taught in a 2-hour session once, right? Building over time, making sure you have faculty that are well trained in this, diversity in all manners, right? From backgrounds, representation in medicine, diversity of thought, right, are all really important. And I think I included 2 quotes here. I don't know if anybody had the chance to watch Ken Burns's, I apologize, I didn't put when this is from. He gave the commencement address at Brandeis University last spring, and I highly recommend Googling it and watching the speech. But here's one quote from it. "And if I have learned anything over those years, it's that there's only us, right? We're all humans. There's no them. And whenever someone suggests to you, whomever it may be in your life, that there's a them, run away. Othering is the simplistic binary way to make and identify enemies, but it is also the surest way to your own self-imprisonment." And I think that this is really powerful because this is all about how do we interact with each other. What's humanism, right? It's that we have a connection. You're a human, I'm a human, right? And that applies to interacting with each other, with trainees, with teachers, with community members, with patients, and so forth. Professional identity formation, again, kind of just mentioning it. This is how we organize it here at our school. Again, we really like to contextualize things. We talk about, what's our community of learners that we're creating here, and who are all the people that are contributing to any individual student's professional identity. And it's certainly folks from the community, it's their teachers, their peers, their patients, their families. And these are the domains, right? Professional behaviors, leadership, growth and pursuit of excellence, and then that central humanism. And I put humanism last because it's the most important, right? So it's kind of building up there. What is humanism, right? We ask that question a lot. In fact, if you recall, we have that 2-week human dimension immersion as the first 2 weeks of our curriculum. And the white coat ceremony takes place usually the last Thursday of those 2 weeks. And in preparation for that, we have our students go through a process where they sort of ask for them, they do reflection for themselves, and then they engage with that 8-person small group of human dimension, and they actually produce a visual slide responding to the prompt, what does humanism mean to me? Because there's a lot under this, right? And if we take a pure approach where it's like, this is the definition and you have to do this, well, that's missing the point, right? Because that medical student is a human, right? And their experiences that they've had, or what drives them, or their goals, or how they feel in certain settings, all is at play here. We have them reflect on that, what does humanism mean to me prompt, again, when they're approaching clerkships and prior to graduation. I did put the Gold Foundation's definition there, which I think is helpful. I think that sometimes in some of these initiatives, we can forget about the patient. So I like to say to faculty, like, when in doubt, center the patient, right? How does this impact patient care is always a good approach. And this is, again, I forget where this is from, an article, but kind of pulling together a lot of what I've been talking about here as we think about humanism. So whole person care, right? The relationship. The robots haven't replaced us yet. The AI hasn't replaced us yet, right? Recognizing universality, the shared human connection, perspective taking, the intrinsic value. Again, getting back to that curiosity and humility. So I will close with one more quote from Ken Burns. Again, a plug to go watch the speech. Listen, be curious, not cool. I just think that's such a fantastic phrase. Leadership is humility and generosity squared. Be in nature, which is always perfect and where nothing is binary. Its sheer majesty may remind you of your own atomic insignificance, as one observer put it. But in the inscrutable and paradoxical ways of wild places, you will feel larger, inspirited. So I'm happy to, thank you, take any questions. I can either stop sharing screen, or there may be particular figures people want. It's always nice to be able to see people. I hope that gave you a sense of who we are and kind of what's guided us, why we've done what we've done. And we've learned many lessons along the way. We continue to, so I'm happy to talk about any pieces of those.
Thank you so much, Miriam. That was exactly what I hoped for and more.
Oh, good. One
I'm
always
going
worries.
no, no. I knew you could never disappoint, even if you wanted to. I'm going to open it up to the group. I know my group, and I know that there will be questions. So just folks, just unmute yourselves and please feel free.
Hi, Dean Hoffman. Thank you for coming and telling us all about the amazing successes you've had. It's a great curriculum. I wish I went to medical school. It makes me wish I did. Anyway, I'm a PhD scientist, and my space is mainly in the first year curriculum. I guess my question is just from a sort of a feasibility. That to me, that just seems like to have required a huge, not just huge institutional buy-in with respect to philosophy, but also resources. I'm just trying to imagine, I don't know how many medical students are in your school. We have over 200. And just, trying to imagine how to coordinate those enduring, meaningful community engagement experiences in a way that's integrated to the curriculum just seems astonishing. So how did that work?
Yeah. So we have 168 students per class. We didn't at first. We had 60 in our first class. We went up pretty fast, but
Wow.
I think this is why I always like to lead, or I've learned that I need to headline. You don't have to do, it would be really hard, in fact, to do all of this all at once for 200 med students per year, right? I think one of the things that we realized very early on was that we really needed a community programs team. And so I love to share the fact that in my office of medical education, I have a community programs unit within the office of medical education. Now, it's grown a lot over the years, a lot grant, from philanthropic funding, but it wasn't so big to begin with, right? So I had, just to give you a flavor of the type of people. So we have a community engagement specialist. So that's a person who builds relationships with different community partners. And so when we started, when this was all just an idea, and before we had any students, we were like, gee, is anyone going to want to do this with us? And so we literally had a little mini bus, and we were kind of driving around New Jersey, meeting with different people. And I can tell you that we were overwhelmed. We had way more people that wanted, and by people, I mean organizations that wanted to partner with us than that we could accommodate, especially in those early years when we were going to have a small class. So I think that there are partners out there that you can find in the community, but there are probably also partners in your health system who may even have some resources, right? So community engagement units, quality patient safety, things like that. And maybe there's a way to partner, because you're right, the institutional commitment is really critical. Now,
Yeah, thank you.
part of,
Yeah, I think we've done
yeah,
that. Oh, I'm sorry, I didn't mean to jump in. I'm just saying, I think
well, yeah,
we do accomplish much of that, at least from my pretty limited perspective. We have elective pathways, but it's not integrated into the curriculum as overtly as it is in what you showed us. So we do achieve that. I also think we achieve that just through more small group discussions, which really very heavy dependent on the skills of the clinician who's leading these small group discussions, because all of these topics are covered in different ways. And and so I think we do try to address that type of integration and making sure that the guiding professional philosophy is one that's centered around humanism, cognizance of social awareness, bias, cultural humility, stuff like that.
yeah. I guess one thing I would say, I totally agree here with everything you're saying. Maybe your clinical reasoning and your clinical skills area, people are a place to start, because if you can get those folks engaged such that students are now being assessed on their diagnostic thinking about all the determinants, right? Assessment will drive the rest. So I think if you're looking for an entree of a way to kind of push that to the next level, that might be one thing to think about. Totally agree about that faculty in the small group room. And so I don't know how things are structured for you guys in terms of faculty time, right? Like that's a big challenge, especially clinical time, but the more you can build up those groups. But I feel so strongly that it's about, this has to be done in an integrated way. Otherwise we're sending the message, this is only important on Tuesdays from 8 to 10 in the morning, you know.
Okay.
And
Dr.
even
Hoffman,
so with our structure, I just want to say we still have those challenges. So yeah.
I see that Dr. Burke was his hand is up, but I know that Dr. Brooks had a question first. So let's go in that order if it's okay with you folks.
Sure. Dr. Brooks?
I have a lot of questions. Thank you so much for this presentation. But I'll ask one in the interest of time and everybody else being here. So I think this is really exciting work. I guess let me ask, I guess, maybe two questions that kind of, I think, go hand in hand. One thing that I think that is amazing about how it seems to me is this idea of this longitudinal project, because what I think many of us have experienced is a project that there's a lot of excitement about for a little bit, and then things get busy, and there is not a structure for what that looks like, you know, once these students kind of move on to the next thing. And so I'm wondering, one, how do you make sure that that project remains robust when the students are involved in clerkships and in clinical settings, when their time is allotted very differently? And then two, what does it look like? How do you maintain that these projects are relevant as the students kind of move through and not just repeating the same things over and over? Because it sounds like you actually have I was in my head, I was anticipating like a much smaller class size, but you have a ton of students similar to us actually. And I'm wondering how you make that, I don't know, stay fresh and also important for the community.
Yeah, you're bringing up really great questions. So I'll try to unpack a few of those. And I will also say we have an academic medicine last page that was just recently accepted on community engaged medical education. So coming to a newsstand near you probably in like 3 years. But so a couple of those pieces, right? Flexible and community-centered, adapting to you know, changing needs is a really important point, right? This is not we parachute in and say, oh, I'm learning nutrition in my course right now, you must need a nutrition intervention, right? At all. And you have to start at the beginning with the idea, you know, and that's another piece of this, right? It kind of inoculating students from the beginning before they learn a hidden curriculum, and then you have to reverse it, which is much harder. So that is really important. So that's where, and I was sort of starting to say this a little bit before, our community programs team is really important because the folks who we work with build relationships with our students, but our students will leave at some point, even if they become residents and even if they become faculty. So our community programs team is an important point of continuity. And again, it's a little bit different if we're talking about the people working with the families versus with the community organizations. And I'm happy to get into all that detail. But that institutional relationship as well as that on the ground. So that's a really important piece of this as well. And something that so two other points to make. One is we over the years, we learned and built in an infrastructure for handoffs from one group of students to the next. And this happens I'll describe 2 ways. So one is towards the end of the core curriculum, the end of the 3rd year, when the students are getting close to finishing that up, we actually have sort of a whole kind of curriculum, for lack of a better word, around transitioning their BP, their family member, to a new pair of students. Many of our BP stays, sometimes they leave. There's a whole process to assess that. And so our students are learning how to say goodbye to patients, right? How do you deal with things like that? So that's a very structured thing where the senior dyad kind of has a handoff, and you know, there's obviously it's a warm handoff to the incoming students, but then also for those where we have the 8 students matched with the community. And this has actually been a really nice thing where part of that first 2 weeks of human dimension immersion and the first 2 weeks of med school, The second year group of 8 that was with Nutley interacts with the new incoming group of 8 that's going to take on Nutley. And they are part of the kind of orienting of the students to that community. You have to do that with limits, and you have to, it has to be very structured and things like that, so that they're picking it up where, right? Because it would be ridiculous if we now just, okay, we're going to start from scratch doing the same thing these other students did a year ago. So that's an important piece of it. We're also, you know, it's how do you balance sustainability? So we've done this great program in the middle schools in whatever town. Well, the schools want that to continue, but what are the same needs and how does it grow? So these are all things that we're really grappling with, and students, faculty, and staff are all involved in that. So I hope that gives a little bit of a flavor.
Absolutely. And I'm going to ask Ellen Berkowitz. This will have to be our last question, although I know we have many more to ask. Ellen?
Thanks so much. First of all, thank you so much, Miriam. What a wonderful, innovative, and creative program in an integrated curriculum that you've developed. I don't know how you've gotten the resources and the ability to sustain this and grow as you go. Mine may be a very short-lived question, but I'm really curious how the reaction of accreditation is to this new curriculum. So, for instance, how does the accrediting body, LCME, how have they responded to this innovative curriculum? That's number one. And number two, perhaps I heard incorrectly, but did you say that you graduated students in 3 years? And if so,
yep.
If so, how has that been accepted by LCME, as well as sort of, is that all students graduate in 3 years, or students within perhaps, one pathway?
Yeah, great question. So just a clarifying question on your first one, when you said, how has the LCME received? Did you mean the community engaged program like Human Dimension, or were there other aspects of the curriculum?
No, the
that you were
integrated program with the community dimension, and also the fact that it's a 3-year curriculum.
Got it. Yeah. So great is the easiest answer. Look, when you're, we were very mindful of LCME accreditation standards as we built everything, right? So that wasn't what drove us, but it was, we were like, okay, let's make our system for this. We need to make sure that we, meet X, Y, and Z criteria. There's been interesting evolution. Those of you who are involved in LCME for your school know in the specific elements that have to do with sort of community service and, I forget the labels that they give them now. I would argue that we need to collectively advocate for the LCME to push things to be about community engaged medical education and service learning, and not on the sort of simplistic parachute in for community service. And I think there's some things that have gotten built more in a good way to this way, but I think there are indications that they may be going that way. So let's work together on that. So yeah, so it's been fine. And I can share 2 references with you. Elke, I can email you. Maybe I did already. One is an article. It's using the layered analysis method to show how we built the entire school, driven comprehensively by the vision. And the other is on the 3+1 model. So all our students complete the 3-year core curriculum, but then they have that individualized 4th year, which if they stay matriculated is really about 17, 18 months, right? And so I see that as a sort of meso level competency-based medical education intervention, right? Because if you have a student who has done really well, they can get 2 degrees, they can get really advanced stuff in their 4th year, or maybe they're ready at 3 years and can go to residency. But also, if you have a student who needed a little bit more time to get their foundational competencies shored up, some of that individual time can be used for that as well. So
but they do meet all curricular requirements within the 3-year.
Yes. And I'm happy to. Yes, exactly. They take step 1 and step 2. They're both graduation requirements. They do that in that 3 years. Happy to talk offline about like LCME and tracks and things like that if that's of interest. But it's been great.
Thank you so much.
Thank you so much. And Taryn's already tacked in the LCME standard relevant to Ellen's question.